So welcome to this webinar, Examining Clinical and Cost Implications of HER2-Positive Breast Cancer Care in a New Era of Value-Based Care, Biosimilars, Clinical Pathways, and Precision Medicine. This program is sponsored by the North American Center for Continuing Education, LLC, and is supported by an educational grant from Genentech. I am Dr. Adam Brusky, who I am a professor of medicine and associate chief of the Division of Hematology Oncology and co-director of the Comprehensive Breast Cancer Center at the University of Pittsburgh School of Medicine, where I also serve as Associate Director of Clinical Investigation at the University of Pittsburgh Cancer Institute. I'll be your presenter today, along with Dr. Edward Lee, Associate Professor at the University of New England College of Pharmacy in Scarborough, Maine. Our disclosures are seen here in this next slide. I'm a consultant for Puma & Roche, and Dr. Lee is on the Speakers Bureau for a variety of organizations as shown there. My goal in speaking to you today is to provide an overview of individualizing therapy in HER2-positive breast cancer with a focus on metastatic breast cancer, and provided on the left side of this webinar platform are additional resources regarding today's topic. Feel free to browse them if you'd like more information. And if you have any questions during this webinar, please enter them into the question box, and Dr. Lee and or I will do our best to answer them in the question and answer session immediately following today's presentation. So with that, I'll start in this next slide, and no two cancers are exactly alike. Breast cancer is a heterogeneous disease comprised of biologic subtypes with significantly different outcomes. And really, this classification of subtypes has led to the development of personalized breast cancer therapy. Personalized therapy, for example, for HER2-positive breast cancer is clearly one of the most important developments to occur in the last 20 or 30 years in breast cancer treatment. And this slide now shows you intrinsic subtypes and chemotherapy sensitivity. This is neoadjuvant chemotherapy with anthracycline and taxane-based therapy for early-stage breast cancer, and both with chemotherapy paclitaxel FAC or AC paclitaxel. Patients who have luminal A or B breast cancer tend to have a pathological complete response rate of only 7%. Patients who have a HER2-positive ER-negative breast cancer have the pathological complete response rates upwards of 35 to 45%, and basal-like breast cancer has pathological complete response rates, again, much higher than those that are strongly ER-positive. And the pathological complete response rate in invasive lobular cancer, which is a very strongly estrogen receptor-positive breast cancer, is only 4.2%. So one of the things we do, actually, when we talk about this, we're going to talk really and focus mostly on the HER2-positive subtype of breast cancer. And basically, we define this by HER2-positive status. Generally, on the surface of normal breast epithelium, there are about 20,000 HER2 receptors in HER2-positive breast cancer, which occurs about probably 15 to 20% of all breast cancer. There's duplication of a region, the HER2 region on the P arm of chromosome 17, which results in increased RNA expression, increased protein expression, up to 1 to 2 million receptor molecules on the surface of these cancer cells, and this actually leads to autoactivation of these receptors and poorer prognosis and worse survival. We test HER2 in this slide by either immunohistochemistry, as shown here, or fluorescence in situ hybridization, that is looking at DNA copies of the cell and comparing it to normal chromosome 17. You can see here there's a variety of definitions that are used. Positive is 3+, and you can see there in that very strongly intense area, 3+ perimembranous staining at least 10% of the cells, or greater than 6 copies of HER2 per cell, or a ratio of HER2 to CEP17. You can see that in the bottom panel there, the ratio of CEP17, those green dots to the reddish dots, is greater than 2. That's positive. Negative is considered weak or no staining. You can see that on the far right side of this panel. And no, as you can see, there's very little amplification of the red dots, really negative. And equivocal is everything in between, and we really try to kind of sort the equivocals out as best as we can to put them into positive or negative. Why is this important? Mainly because we have monoclonal antibodies, both Trastuzumab and Pertuzumab, which bind to the HER2 molecule and interrupt its function. Either Trastuzumab binds to a domain on HER2 and interrupts its transduction of signals into the cell, where Pertuzumab binds to another domain of HER2 and blocks its interaction with HER3. All of these lead to decreased function of the HER2-HER3 receptor complex. There are tyrosine kinase inhibitors, in particular Lapatinib, which is an oral drug that binds to the tyrosine kinase domain inside of the cell. There are also antibody-drug conjugates, we'll get into a little bit later, Trastuzumab, Emtansine, or TDM1, which actually bind to the HER2 and are internalized by the cell to actually result in release of chemotherapy. So turning now to adjuvant therapy for HER2-positive breast cancer, again, really has revolutionized. This slide shows the Trastuzumab, which is a humanized anti-HER2 monoclonal antibody targeting the HER2 protein. It has high affinity and specificity. It's mostly a humanized monoclonal antibody. It's 95% human, 5% murine. The hypervariable region is the mouse protein that was derived from a monoclonal antibody. Because it's humanized, it is not immunogenic, and that Fc fragment recruits immune effector mechanisms in addition to actually blocking downstream HER2 pathways. So there have been multiple trials over the years, and really that have shown the benefit of adjuvant Trastuzumab. There was the HERA trial, as shown above in the top panel, which took any chemotherapy and/or radiation and gave either observation, Trastuzumab every 3 weeks for 12 months, or Trastuzumab every 3 weeks for 24 months. NSABP B31 and NCCG 9831 all gave 4 cycles of Adriamycin and Cytoxan, followed by paclitaxel in various doses with or without Trastuzumab. BCIRG-006 was a trial, and we'll get into this a little bit further, where also was an adjuvant study of 3,000 women with all receiving either anthracycline and docetaxel with or without Herceptin, or docetaxel, carboplatin, and Herceptin, or Trastuzumab, docetaxel, carboplatin, and Trastuzumab every 3 weeks to complete 18 doses. And again, this actually, BCRG-006 tested a non-anthracycline containing regimen. There were 2 smaller trials that were also included, FIN-HER and PAX-04, which do have some limited data, but because they're so small, we tend not to use those when we make clinical decisions. In this next slide, it just shows the efficacy of many of these trials. Basically, all of the studies, NSABP and NCTG 9831, HERA, BCRG-006, in all arms, all containing Trastuzumab, resulted in a substantial improvement in disease-free survival at 3 to 4 years, and a substantial improvement in overall survival at 3 to 4 years. The FIN-HER trial, which also was a similar design, showed a substantial disease-free and overall survival benefit, where PAX-04, which really compared just 2 different regimens of anthracycline followed by Trastuzumab, had a small but significant benefit from the FEC arm of the trial. The bottom line to all of these trials is that Trastuzumab does provide a substantial hazard ratio improvement of 0.5 to 0.6, and a hazard ratio improvement in overall survival of 0.5 to 0.6, regardless of the trial that it was used in. And just to briefly go into a few trials, this just shows you the data, which was actually quite dramatic when it was first presented almost 10 years ago. And this is a trial, again, a combined analysis of NCCTG B31, NCCG 9831, and NSABP B31. And putting these 2 trials together, you can see that the ACTH arm had a substantial improvement in absolute benefit, both in terms of, in this case, disease-free survival at 3 years and 4 years. And this has been maintained now in the most current data up to 10 years. In this next slide, however, we also have a non-anthracycline containing regimen, docetaxel, carboplatin, and Trastuzumab, which has, in this trial, essentially equivalent, in this case, 5-year disease-free survival of 81% versus 84% for ACTH, but has a much less cardiac toxicity. The incidence of congestive heart failure with AC followed by docetaxel or paclitaxel Herceptin is about 2 to 4%. With docetaxel, carboplatin, Herceptin, it's under 1%. This is a non-anthracycline containing regimen that works just as well as the other regimens and has less toxicity. So there also has been a lot of data with neoadjuvant therapy for HER2-positive breast cancer. And again, the idea behind neoadjuvant therapy, as shown on the slide, is really having a large tumor in a smaller breast, and a patient desires breast-conserving surgery. The idea, again, to try to shrink the tumor to make the surgery easier with clear margins. Absolute indications include inflammatory breast cancer or breast cancer that appears to be locally advanced, that is fixed potentially to the axillary, fixed to the chest wall, or matted axillary nodes, or other tumors that invade the skin, or have other poor prognostic signs. And so in this slide, we have patient selection for neoadjuvant chemotherapy. Generally, patients that are ER negative, HER2 positive with high-grade proliferation markers are good candidates. Unicentric disease also, that is ER positive but low grade, probably should get neoadjuvant endocrine therapy if we desire to shrink the tumor. But if there's multicentric disease throughout the breast in multiple quadrants, clearly these patients require mastectomy. We often give neoadjuvant chemotherapy if we know we're going to give chemotherapy anyway to women, mainly because these women, we want to check to make sure their cancers respond to chemotherapy, and they're going to need chemotherapy anyway. So we tend to try to do this to get this out of the way. So the major advance in the HER2-positive space really has been Pertuzumab in neoadjuvant therapy. And again, Pertuzumab, as shown here, binds to the domain 2 of the HER2 complex and prevents the interaction of HER3 with it. This is just shown in this cartoon. HER2 binds to the dimerization domain. Pertuzumab binds to the dimerization subdomain 2 of the HER2 receptor and inhibits HER2-forming dimer pairs and provides more complete HER2 blockade, where Trastuzumab suppresses HER2 activity by binding to the subdomain 4 of the extracellular domain. So there have been a bunch of trials, basically, and I'll just focus on two. The first one is NeoSphere, and NeoSphere was a trial with women with locally advanced or inflammatory breast cancer greater than 2 centimeters, and were randomized to docetaxel Trastuzumab, the same chemotherapy with Pertuzumab, Pertuzumab alone, or docetaxel Pertuzumab. Then they all had surgery. Then at that point, they all had anthracycline-containing chemotherapy, followed by a year of Trastuzumab. And in this trial, to show you the combination THP had a 45% pathological complete response rate. That's no cancer in the breast or lymph nodes, which was about 20% better, 15 to 20% better than TH alone. Interestingly enough, the two antibodies alone had about a 20% complete pathologic response rate, whereas docetaxel and just Pertuzumab was only about 24%. So the addition of Pertuzumab to Trastuzumab resulted in a substantial benefit. Another trial that was relatively similar was TRYPHAENA, which took HER2-positive early-stage breast cancer. About 225 women were randomized to receive Pertuzumab, Trastuzumab, and Efficacy chemotherapy and docetaxel. The same chemotherapy with the Pertuzumab, Trastuzumab, docetaxel would be given after. This is a test of cardiac toxicity of giving the anti-HER2 antibodies with anthracyclines. And finally, there was a trial. There was an arm of Pertuzumab, Trastuzumab, docetaxel, and carboplatin. In all of these arms, as shown in this next slide, basically all had total pathological complete response rates of 55 to 64%. And so for this reason, all of these regimens are included as possible regimens of neoadjuvant therapy for HER2-positive locally advanced breast cancer, and are now actually the standard of care approved by the FDA. In the next slide, there's actually been a large trial, Affinity, which actually gave women chemotherapy as adjuvant therapy. Everybody got chemotherapy with Trastuzumab, with either placebo or Pertuzumab. This trial was just presented at the National ASCO meeting a few weeks ago, and in this trial, there were modest improvements to Pertuzumab over placebo, and so therefore it's likely that Pertuzumab will be approved by the regulatory authorities in the U.S. And in Europe in the next few months, I suspect. As we discussed before in this slide, Lapatinib binds to the intracellular domain and inhibits downstream effectiveness of the HER2 molecule. There was a large clinical trial called NeoAlto, which actually added Lapatinib, the oral Lapatinib, to Trastuzumab, and showed a doubling of the pathological complete response rate, both in the breast only and in the breast and lymph nodes. You can see here in the 45 to 50% range versus about 25 to 30% with the individual therapies alone. However, interestingly enough, this does not translate to improved benefit in these women in terms of disease-free survival at 40 years, and so Lapatinib will likely not be moved forward as adjuvant or neoadjuvant therapy in this setting. Turning now to HER2-positive metastatic breast cancer. Again, this was presented several years ago in the New England Journal of Medicine, the Cleopatra study. And in this slide, in the Cleopatra, 808 women with HER2-positive metastatic breast cancer were randomized to receive Trastuzumab, docetaxel, and placebo, or Trastuzumab, docetaxel, and Pertuzumab. In terms of progression-free survival, it was improved in this slide, as you can see here, by about 6 months, for about 1 year with Trastuzumab alone to about 18 months with Trastuzumab and Pertuzumab. But I think what's most important in this data set is that there was a really astounding improvement in overall survival of these women from 40 months up to 56.5 months, which is approaching 5 years. And so now women with first-line metastatic HER2-positive breast cancer can now live upwards of 5 years with combined anti-HER2 therapy with chemotherapy when given in the first line. In terms of second-line therapy for HER2-positive metastatic breast cancer, we have Trastuzumab Emtansine, as shown in this slide. It basically is a Trastuzumab molecule with Emtansine bound to it. And what happens is that the molecule binds to HER2. It's internalized by the cell. The HER2 molecule is destroyed in the lysosome, releasing the Emtansine, which is a microtubule depolymerizer, and inhibits microtubule formation and chromosome separation, causing death of the cell. And so in this trial, EMILIA, 980 women with HER2-positive metastatic breast cancer who had progressed on Trastuzumab and a taxane were randomized to TDM1 or a standard therapy, capecitabine, with Lapatinib. In this particular trial, the TDM1 had a progression-free survival of 9.6 months versus 6.4 months with capecitabine and Lapatinib. But what's most important in this, if you look at it about 2 years, about 30% of the women on TDM1 had not progressed, where virtually all the women on capecitabine and Lapatinib had. And this actually resulted in an overall survival benefit at 2 years of about 64% versus 47% with capecitabine and Lapatinib, which I think, again, shows that we have improved the survival of these women with metastatic disease substantially with a novel therapy. This actually led to a trial called MARIANNE, which took women with early first-line metastatic breast cancer and randomized them to Trastuzumab docetaxel or Trastuzumab paclitaxel versus TDM1 and placebo or TDM1 and Pertuzumab. And in this trial, there was actually, interestingly enough, no benefit in progression-free survival, statistically, between Trastuzumab and chemotherapy. Standard chemotherapy, TDM1 or TDM1 and Pertuzumab, you can see here. The PFS was 13.7 months versus 14.1 months versus 15.2 months. And interestingly enough, at the latest ASCO meeting, what was found was that the survivals of all of these women were about 51 to 53 months. So there's actually no difference in overall survival as well. So TDM1 is an interesting therapy. It does not have hair loss. It has minimal myelosuppression. It has no neuropathy or minimal neuropathy. It's a very interesting drug, and I think it's an option for first-line therapy for metastatic disease if people feel that THP or one of the more stronger chemotherapies is too much because the survival is the same. But I think the standard of care still does remain THP for first-line therapy at this point. So to kind of summarize this section, there have been many milestones in the management of HER2-positive metastatic breast cancer. I think the Cleopatra trial has shown us that Trastuzumab, Pertuzumab, and docetaxel is superior to Trastuzumab and docetaxel substantially. There's modest benefits to the addition of Lapatinib to letrozole we didn't really talk about, or Trastuzumab to anastrozole in triple positive, that is HER2-positive, ER-positive breast cancer. And in the second-line therapy, I think EMILIA adding, substituting TDM1 for Lapatinib capecitabine results in a substantial overall survival benefit, with more modest benefits adding Trastuzumab and Lapatinib to capecitabine. So the bottom line is that basically TDM1, as we've shown in the last slide, the recommendations for second-line therapy are really TDM1 if a patient has progressed on first-line THP, or they've occurred within 12 months of finishing their adjuvant therapy. So to summarize everything, I think that at least in terms of early-stage breast cancer, Trastuzumab, and now Trastuzumab, Pertuzumab, in addition to standard chemotherapy, remains the standard of care. We have several options. We have AC followed by THP, or we have TCH if you do not want to, if you are concerned at all about cardiac toxicity of concurrent anthracycline and Trastuzumab. In the metastatic setting, we have THP, which is the standard of care, and if progressive disease occurs within 12 months of adjuvant Herceptin, or if a woman progresses on first-line THP, TDM1 is then the appropriate therapy. So with that kind of was a whirlwind summary of where we are in terms of the therapeutic indications for anti-HER2 agents in the treatment of HER2-positive early-stage and metastatic breast cancer. I will now turn things over to Dr. Lee to begin his presentation.
Thank you, Dr. Brusky. And before we get into my section, I'll just start with a quick polling question. And this question states, which of the following strategies has or have been supported in the literature to improve overall survival or reduce costs when treating breast cancer? Is it A, adherence to pathways, B, adherence to guidelines, C, use of biosimilars, or D, use of value frameworks? So my section is about cost containment strategies for HER2-positive breast cancer, guidelines, pathways, value frameworks, and the emergence of biosimilars in breast cancer care. There's a lot here, and I think the reason why we're talking specifically about this is if you look at the top expenditure drugs, just in general, anti-neoplastic agents, but also top 25 drugs by expenditures in hospitals. In 2016, you see that anti-HER2 therapies are on the top of the list of drug-related expenditures. In the clinics, it's ranked number 3 and 6 for anti-neoplastics. That's about $2.8 billion in terms of expenditures, again, just in 2016. In the hospitals, it's number 10 for all hospital expenditures, drug-related expenditures, that is, with about $490 million. And when you add all of these numbers up and you say, if we could just save 30% on our price of Trastuzumab, this represents a large number in terms of $775 million saved. So we have a lot of opportunity to try to bend the cost curve in this area. And so the first question is really, what about following guidelines? We practice evidence-based medicine and espouse to practice evidence-based medicine. And part of the reason for that is not just to optimize care, but potentially reduce costs in our patients in terms of costs of missed opportunities or cost of poor care in general. And so the question is, does a guideline adherence actually result in better outcomes and or decreased costs? And so in this particular study that was recently published, this was a retrospective cohort in Italian women diagnosed with breast cancer, and they looked at those who were adherent or non-adherent to guidelines based on 7 different process indicators. And their primary endpoint was looking at overall survival, and what they found was that there was a 30% lower risk of death for those who had actually adhered to the pathways versus not. And this is great, good news, and kind of confirms the fact that we should be following guidelines, but again, there are no costs incorporated into this type of analysis. And really that's, I think, what oncology pathways are for. They're the next evolution in terms of clinical practice guidelines. Just to recall, clinical practice guidelines are evidence-based. They assist providers in making selections that result in high-quality care, and typically these are algorithms with many different acceptable options. And pathways are really a narrowing approach towards these clinical guidelines. They're protocols, and they often include only the selections that are the most cost-effective treatment options that have the greatest impact on efficacy and minimizing toxicities. And so, in other words, pathways incorporate that conscious cost decision on top of just what is the evidence in terms of efficacy and safety. And so because of this, the ASCO actually has a few recommendations for when pathways are developed, what features should they have. And there's a few of these recommendations listed here, and you can pull up the article to take a deeper dive into this. But really the biggest aspect of this is that the pathway should be transparent in its development process of what information goes into developing pathways. It should address the full care spectrum and not just simply one line of treatment. They should also be continuously updated, but also recognize that you can't take a one-size-fits-all approach towards treating patients. So these pathways have to recognize that there's going to always be some level of individualization here. And pathways need to be researched in terms of understanding, by following pathways, whether or not you get at that better outcomes and lower costs that they espouse. And so because of that, we can actually take a look at what the literature says in terms of whether or not pathways actually do work in terms of lowering costs and increasing efficacy. Again, providing the most cost-effective care in breast cancer. And what we see is that there actually is a lack of published evidence in the breast cancer space. There's been a few publications that look at evaluating pathways. For the most part, they've been done in non-small cell lung cancer and colon cancer, also in the supportive care space, but we really don't have a lot of published information, that is, regarding pathways for breast cancer. And I'm sure the pathways companies have their own data, but we don't have that information in the public domain. So that goes to the next point in terms of, how can we still get at the conundrum of providing the most effective care at the lowest cost. And the next concept that's been out there for a few years now is the concept of value frameworks. And these are strategies really to describe a treatment's efficacy in context with the cost. And really the three biggest value frameworks that are out there, there are many more value frameworks, but I think the ones that people are talking about the most are the ASCO value framework, the ESMO magnitude of clinical benefit, and the NCCN evidence block. So again, these are ways to describe treatment, specific treatment efficacy in context with the cost. So a little bit different from pathways in regards to the fact that pathways are essentially protocols, but these are just mostly describing one treatment at a time. We haven't really addressed the standpoint of reducing costs, specifically in breast cancer. So what do we have out there that actually has reduced costs, and do we have any historical perspective on that? So if we took a deeper look back at drug expenditures and oncology drug expenditures specifically in 2010 to 2014, what do we see? We saw a low percentage growth in terms of oncology drug expenditures from year to year. Specifically from 2011 and going on to 2013, you actually saw a complete moderation of growth between 2012 to 2013 in terms of total oncology drug expenditures. And how and why did this happen? Well, during these time periods, you actually had products going off patent. So we had generic gemcitabine, we had generic docetaxel, and generic oxaliplatin actually entering the market and having this situation of more competition, which drives down costs specifically for these products. But after that, we didn't have any major product. So prior to 2013, these three were the major small molecule cytotoxic chemotherapy expenditures. These were the ones that, from a pharmacist perspective, kept us up at night in terms of drug budgets. But after that, we had these novel monoclonal antibodies being approved, so the immuno-oncology agents, Pertuzumab, those sorts of molecules being approved, but nothing was basically coming off of exclusivity to moderate that growth. So now we usher in the era of biosimilars and the potential for biosimilars to actually be in that space and create some competition in that space to hopefully lower our drug expenditures. And so many different companies have done some of these analysis in terms of the potential of cost savings for biosimilars, and I think the figure that's been touted over and over again has been about $44 billion or so over 10 years, which is a large amount of money to be saved with potentially with biosimilars. And so we have to look at biosimilars as, what are these types of products and how do they kind of fit into our current understanding of the evidence and in terms of efficacy and safety and using these products to treat our patients. So if we look at the biosimilar pathway and how that compares to a reference product or an originator product, and on this slide, the originator pathway is on the left-hand side, and we talk about how the clinical studies are extremely important for releasing a originator product to market, for having that become FDA approved. And certainly there's analytical characterization of the molecule as well as preclinical data and clinical pharmacology, but from a clinician standpoint, it's really the clinical studies in terms of efficacy and safety that convinces us to use these products. However, for a biosimilar, the exercise is one of biosimilarity. So to what extent is the biosimilar similar to the reference product? The purpose of this regulatory pathway to get a biosimilar approved is not to reestablish benefit in that it is safe and effective per se. So again, the point of this pathway is to ensure that a biosimilar is essentially comparable or highly similar to the originator product, the reference product. And so the paradigm of data is going to be different in that the analytical and preclinical data, looking at the structure, the function, is going to be far more important than the clinical studies. And certainly the clinical studies will be done in terms of clinical pharmacology, pharmacokinetics, and the clinical studies looking at a sensitive population in using a sensitive endpoint. Basically, that type of study is designed to detect a difference in the products clinically if actually one existed. And so how do biosimilars actually do that? To be highly similar, they're reverse engineered according to the target profile that the molecule needs to have, and they know what the target profile is because they purchase batches of the reference product over time and develop that product profile and design their manufacturing approach actually to meet those specific target specifications in terms of those quality attributes. So they utilize a concept called quality by design, which is supported by the FDA and internationally recognized. And this is a systematic approach that, again, begins with the objectives in mind, the objectives of having the target profile in terms of these critical quality attributes, and then designing an iterative process in their manufacturing process to be able to meet those target attributes and to manage that and have a consistent product over the life cycle of the product. And so what this allows them to do, if you look at one particular study of the physicochemical and biological characterization of a biosimilar Trastuzumab, and I'm just going to call this biosimilar Trastuzumab or proposed biosimilar Trastuzumab number 1, they were able to demonstrate comparability and similarity between these critical physicochemical attributes and biological properties listed on this slide here. So again, these were explicitly compared to the reference product using orthogonal methods, and in this particular exercise, in terms of understanding these features and the similarity between the proposed biosimilar and the reference product, helps out in determining what sorts of non-clinical and clinical studies are needed. So I'm not showing you the data here, but if you look at the reference and pull up the article, in this particular situation, this proposed biosimilar Trastuzumab did demonstrate that high similarity in these different attributes to the reference product. So after that, the next is to evaluate a proposed biosimilar clinically, and the first step of this, that's what the FDA says is fundamental, is a pharmacokinetic exercise. So in this situation, I've shown you what I'm calling proposed biosimilar Trastuzumab number 2. So this is a different product than number 1, and I'm going to talk about many different products, mostly because I don't want to talk about one specific biosimilar, but the fact that there are many out there. But in this particular data package, if you look at the pharmacokinetics here, what they did was they compared their proposed biosimilar with EU Trastuzumab and US Trastuzumab. As you can see that the data shows that in terms of the pharmacokinetic parameters, it fell between the 90% confidence interval fell between the 80 to 125% that's necessary to demonstrate bioequivalence. And so this study, again, showed that these were bioequivalent products to each other. If you look at the adverse events, they were consistent across arms, and only 2 samples actually tested for anti-drug antibodies. It's important to note that this was in healthy volunteers. So after this bioequivalence study is completed, then it's time to move on to the clinical studies, the clinical comparative studies. And this is going to be a little bit different than what we're used to in terms of the endpoints and the study design that we are used to looking at for when a new product is approved, a new molecule is approved that demonstrates safety and efficacy. Because we know that the preferred endpoint that we want to look at is progression-free survival or disease-free survival or overall survival, and those are the endpoints that really matter to us as clinicians. However, when you're talking about a biosimilarity exercise, these are actually not sensitive endpoints for establishing that comparability between the biosimilar and the reference product, because these endpoints of survival are influenced by many, many factors, such as tumor burden, disease status, or previous or subsequent treatment. And so therefore, in order to get at having a sensitive population and sensitive endpoint, that really means reducing these patient and disease-related factors. So you need a homogeneous population of patients. So again, that would essentially mean just one indication or one population of people receiving a similar treatment. And what you're going to be looking at least from the EMA guidance, is overall response rate at a certain time, or the percent change in tumor mass, or if available and clinically relevant, the pathologic complete response. So these actually represent, according to the European Regulatory Authority, represent actually the sensitive endpoint, and the homogeneous population would be, again, that sensitive population. In this type of study, you can collect survival outcomes, but it's recommended to interpret those with caution. And the type of study design that we'll be looking at is one of equivalence, where a predetermined equivalence margin, that's the delta, will be established by looking at the literature and doing a meta-analysis and determining what is actually a clinically meaningful difference if one were to exist. And so that's how the delta is decided as the equivalence boundaries by which the biosimilar products should not go over in terms of their confidence interval. So if we apply this to real life and look at biosimilar Trastuzumab number 3 now, or proposed biosimilar Trastuzumab number 3, and a comparative clinical trial of this particular product, this was a multi-center double-blind randomized equivalent study of 500 patients, randomized, so these patients had HER2-positive metastatic breast cancer, randomized to receive either reference Trastuzumab or the proposed biosimilar Trastuzumab plus a taxane, and they received 8 cycles over 24 weeks, and they measured the response rates for this. Again, the response rate would be the more sensitive endpoint according to the European guidance documents. And if you look at the outcomes of this, the response rates were essentially the same or comparable between the arms, with the proposed biosimilar versus reference arm, with the ratio being 1.09, and the confidence interval, the 90% confidence interval, actually fell between that predetermined equivalence margin of 0.81 to 1.24. So based off of this and this data, this product was deemed to be equivalent to the reference. And looking at the rates of adverse events in terms of neutropenia, peripheral neuropathy, diarrhea, they're all similar between the cohorts. So the next question to this would be, well, this was really just one homogeneous population of patients, and we use Trastuzumab in many different indications and many different other populations, and the labeling even says so as well. So how do we know that we can apply this data and use a biosimilar Trastuzumab in other indications as well. And so that goes on to the Extrapolation Framework, and this is established, it's a fully established regulatory framework. The FDA uses this, and what extrapolation means is that you want to extend conclusions from one population that was explicitly studied to other populations, or in this case, indications that were not necessarily explicitly studied, to infer whether or not the product would be able to be equivalent to the reference product in those populations as well. And the exercise is based off of two realms. One is what you know about the biosimilar in terms of the totality of the evidence, so that's the pyramid to represent the data paradigm that I discussed before. So again, that's the analytical, non-clinical, and clinical studies that were done previously, but also what we know about the reference biological product in terms of the disease factors such as mechanism of action, what we know about the pharmacokinetics and biodistribution of the product, immunogenicity, what we know about whether or not the product forms anti-drug antibodies, or whether or not a person would produce anti-drug antibodies to the product, and what the toxicity profile is. And the exercise is one of asking, are there any differences across the populations, from population 1 to population 2 or 3 or 4, that would be of concern? So any differences in kind of the realms that I talked about, disease factors, patient factors, immunogenicity factors, or endpoint factors, are there any differences that would be of concern given what we know about the reference and the biosimilar? And so essentially what this means is that if population 1 and population 2 really don't confer any differences in all of these different factors of disease, patient, immunogenicity, and endpoint, and the biosimilar totality of the evidence shows that it is highly similar to the reference product, there should be no concerns about extending the conclusion to saying that we could use the biosimilar, that the biosimilar would be the same as the reference product in indications 2, 3, or 4. And so this is done routinely at the regulatory level, and you would see that a biosimilar could have the same exact labeling as the reference product, even though it wasn't explicitly studied in those particular situations. And so the next concept that we need to talk about is immunogenicity concerns, because these are monoclonal antibodies. They're protein products that we administer to patients, and so there actually is a risk of immunogenicity with all protein products that we administer to patients. And so the things that we worry about are things like anti-drug antibodies that could confer loss of efficacy, or immune effects such as anaphylaxis, serum sickness, or what's really bad is if neutralization of endogenous proteins actually occurs. And so immunogenicity is explicitly studied throughout the development phase in terms of the pharmacokinetic studies, but also the clinical comparative studies, looking at endpoints such as antibody formation or cytokine levels in a comparative parallel study approach. And that's good. However, we all know that monoclonal antibodies have some rare but serious adverse effects. That's, again, not unique to biosimilars, but because of the biological product itself, the fact that it is a biological product. And so when we talk about addressing rare but serious adverse events, that's where pharmacovigilance comes into play. And pharmacovigilance is a regulatory concept that's applied to all FDA-approved products, and not just biosimilars, not just reference products, but all FDA-approved products, to ensure that we can assess and identify what are the risks of the product in the real world. And so biosimilars would fall under that same regulation, the same guidance documents that the FDA produces, in that there needs to be a way to actually trace these products in real time to ensure that again, if there are issues with the product, that they would be reported to the correct authority. And so our responsibility as healthcare practitioners is actually to provide that reporting and correctly attribute the safety event to either a biosimilar or the reference product or whatever product that actually caused the event. And from there, after the risks are adequately characterized, then the FDA may or may not decide to introduce a risk minimization or management plan depending on what that risk actually is. The last regulatory concept I want to talk about with biosimilars is this issue of interchangeability, and biosimilars may have what's called an interchangeability designation on top of being a biosimilar, and what this requires is a different data standard for biosimilarity, because the goalpost or the purpose of being interchangeable is to demonstrate that that there is no risk of increased toxicity or diminished efficacy if you decide to alternate or switch back and forth between the interchangeable biosimilar and the reference product. So for these types of products, from a regulatory standpoint, the FDA has, at least in draft guidance form, talked about how this would require a dedicated switching study and possibly post-market monitoring, depending on if the product itself has significant issues with rare but serious adverse effects. So again, those post-market monitoring would be the pharmacovigilance studies that I described earlier. The study endpoints for the switching study actually would be PK/PD, because that is actually the sensitive endpoint there. Immunogenicity as well, and safety as well. These are the sensitive endpoints. Efficacy is actually not an adequately sensitive endpoint from the FDA's perspective, at least in draft form right now. The actual data package and the study design is going to be a little bit different depending on what the molecule is. So we can expect a different data package for like a biosimilar Trastuzumab versus something for supportive care. And the impact of having interchangeability is one that it would behave like a reference product when you talk about substitution at the pharmacy level. So we know that pharmacists either are legally obligated or enabled to substitute a therapeutically equivalent lower cost product under under pharmacy practice laws, and there have been biologic substitution laws introduced in various states that are very similar to the generic substitution laws, except for the fact that the biological product under consideration for substitution must first be labeled as interchangeable or designated as interchangeable by the FDA. And there are usually provisions to allow prescribers to write brand medically necessary and for prescribers and patients to be notified, which are very similar to generic laws. So again, the interchangeability designation would allow a biological a biosimilar to essentially behave like an AB-rated generic in the healthcare practice. So this sounds all good, but really, what are the potential barriers to having biosimilars in practice, and so what are they, and how can we overcome this? So if we look at kind of a review of the literature in terms of what are some barriers, you can see that they fall in different domains in terms of the formulary analysis, how we manage the products in terms of our inventory systems and order management systems. There's that financial analysis in terms of what's cheapest or what's the most cost-effective product for the patient, but also education as well. And so all of these can be boiled down into the fact that we as the stakeholders will actually determine the outcome of biosimilars. So if we look at from biosimilar availability to utilizing the product and what we believe to be the biosimilar outcomes to society, such as lowering costs, increasing access, and facilitating innovation, the stakeholders involved, such as the providers, payers, and patients, will have to have these expectations that the biosimilar will actually have an impact on price, that it's the same efficacy profile, same safety profile, that we're able to switch and substitute according to state laws, and that the packaging and kind of the way that it's available to us will be consistent with how we utilize these products in the real world. So our perceptions of these expectations actually will be the drivers for utilization. So really the biggest barriers and the challenges fall onto what are the stakeholders' perceived risks of biosimilars. And so these aren't, on this slide I don't have listed the actual risks, but what are the possible perceived risks of biosimilars. by the stakeholders. So one is a lack of awareness and knowledge, and certainly the disagreement about whether or not the biosimilar is safe and effective is certainly going to be a big barrier towards adoption, and also disagreement with the with what I just presented in terms of the trial design, the endpoints, being unsure about whether or not you get cost savings with it, but also loyalty and to not only just a particular product but to the status quo as well. So those are kind of those perceived risks that are out there that stakeholders will have to overcome, and a lot of this has to do, being able to overcome that has to do with education on what the challenges actually are, or what the data actually is, and to understand the regulatory process of biosimilars. On the other side is that when we talk about formulary review, the data paradigm and off-label indications is drastically different, and that's in and of itself a unique challenge that I'll be walking through in just a little bit. But also in terms of cost issues, we know that the biosimilar may not be the least expensive product based off contracting, but the fact that they're available to spur competition should will likely, and we have some data to support this, lead to lower prices or lower expenditures overall. And so the question is, also regarding cost is, will biosimilars have similar patient support programs in terms of helping to lower patient out-of-pocket costs as well? So I talked about the challenge in terms of the data paradigm and off-label indications, and I just want to walk through one exercise in terms of how to, what the actual issue is and how to get around this. And so if we look at the Trastuzumab label right now, it says the treatment of HER2-positive or HER2 overexpressing breast cancer, and let's assume that the biosimilar will obtain this exact labeled indication. If we look at the Pertuzumab label, it says use in combination with Trastuzumab and docetaxel, and you can read the specific language there. But you see that the Trastuzumab label doesn't say anything about in combination, and the Pertuzumab label doesn't really explicitly say if it's reference Trastuzumab or biosimilar Trastuzumab. So the question then becomes one of, is there enough evidence, or is it really off-label to utilize a biosimilar Trastuzumab when it's in combination with Pertuzumab? And we can get around this challenge by utilizing the extrapolation exercise that I just described to help out with the scientific justification for using this. So if we think about a hypothetical biosimilar, and I'll just call this biosimilar Trastuzumab number N, and if we kind of walk through this extrapolation exercise of whether or not we believe it's okay to be given with Pertuzumab, and let's just say the biosimilar evidence comes back that it's highly similar with fingerprint-like similarity, which is an FDA term that basically says that it's the highest level of similarity between the reference and the biosimilar product, and the clinical studies show that there are no clinically meaningful differences within, and let's just say it's a neoadjuvant indication. And we look at the reference biological product experience, and so again, we're considering justifying giving the biosimilar Trastuzumab with Pertuzumab versus with just chemotherapy. And we know that in terms of mechanism of action, it's no different. It's the same across those different populations and how you would use it. Patient-related factors, there's actually data out there, published data of the reference product that shows that there's no issues in terms of PK and Pertuzumab affecting Trastuzumab pharmacokinetics when you co-administer Pertuzumab with Trastuzumab. And let's just say that in terms of the clinical studies, and we can kind of see this with the currently published proposed biosimilar Trastuzumab studies, that there are no differences in safety profile or ADA formation or other toxicities, and they're all consistent with what's been published in the literature. So with that, we don't really expect there to be any differences across these populations that would be of concern. So in this situation, it would be justified to use Pertuzumab with Trastuzumab for metastatic breast cancer, HER2 overexpressing metastatic breast cancer. So this spins off into another challenge that's more on the regulatory side of, we use many different regimens for off-label appropriately, and the guidelines are full of off-label recommendations, and really it's up to the compendia and guidelines to be the curators of what is considered to be appropriate off-label utilization. And we know that they utilize experts to review the evidence, interpret the evidence to support that, but typically that evidence is a phase 2 or phase 3 trial. And we know that the exercise of biosimilarity is not going to be the same for demonstrating safety and efficacy with newer originator products, again, those 351A products. And so really it's about using the extrapolation exercise, looking at the totality of the evidence and justifying whether or not a biosimilar can be used for a specific off-label indication. So the guidelines, compendia, and those other people creating these coverage policy determinations have to take this paradigm into account when they determine what are the appropriate biosimilar off-label uses. So if we translate how that goes into the formulary process and having formulary discussions, again, it's going to be that scientific and clinical information, looking at the totality of the evidence everywhere from the analytical data of the physical-chemical characterizations all the way up to the clinical comparative studies, taking the post-market experience, and looking at the extrapolation exercise if there was one needed to justify its use in perhaps an off-label indication or even another on-label indication as well. So it's integrating that with the cost and administrative data information in terms of what is the price going to be, but also understanding that the use of a product, and if you expand access to a product, can actually help to influence population health outcomes and have a budget on the total budget and not just on the drug budget. So what I mean by this is that if you expand access to a much more effective product that can perhaps lower something like hospitalizations, which will save money down the line in terms of your total budget impact, but also improving population health overall. So looking at all of these different impacts has to be done at the formulary review level, and from there requires education to fully implement this in terms of what the coverage policy is and how do biosimilars get integrated into utilization management pathways and treatment pathways in general. So if we look at, and this is the last slide I'll talk about before we end here, is that biosimilars have the ability to, or the potential to decrease costs, but that fits into the overall broader, grander scheme of what we're trying to achieve is increase our quality adjusted life year for our population at a lower cost. And I think having a biosimilar Trastuzumab out there will be one piece of the puzzle in that it'll foster competition, lower prices across all these products so that these products will be integrated into formularies and pathways, but also with everything else going on in terms of payment based off quality indicators, and not having payment be tied to fee-for-service and having risk-based contracting. In the short term, we're probably going to see the utilization of lower-priced products with cost minimization and higher utilization of the most cost-effective regimen, which can lead to better adherence to guidelines, which we know is a good thing, utilization and appropriate utilization of newer innovative therapies, because now we have the money to pay for those, and which should improve our long-term outcomes, as I previously described. So that is it with my section, and just to close, I'd like to just say that biosimilars are highly regulated products. They're highly similar to reference with no clinically meaningful differences. They have to demonstrate that before they enter the market. We have some challenges around biosimilars. Most of that resolves around our data paradigm shift and the understanding that and how we evaluate biosimilars. And from the managed care perspective, the implementation really needs to incorporate not just the cost, but the total budget impact and how expanding the utilization of biological products in general will affect population health. So with that, this concludes my presentation, and we will now be moving into the question and answer session.
Good afternoon, and thank you for joining us for today's webinar. My name is Edward Lee, and I will be your moderator for today's Q&A session. Joining me today is my co-presenter, Dr. Adam Brufsky. As a reminder, if you would like to ask a question, please type your question into the question box. Our first question today is about patient education, and the question reads, patients are often weary to use generic products and may feel similar about biosimilars. How can we circumvent this perception and improve patient education regarding biosimilars? And certainly we hear this all the time where patients are weary about generic products. But at the end of the day, I think there's good data to show that patients really trust their providers and prescribers about what products that they're ultimately going to receive. And some recent surveys provide us some information about how patients actually trust their prescribers to provide them with adequate information about biosimilars. So really it's about us as prescribers and providers to feel comfortable about the data with biosimilars and recognizing that the paradigm for biosimilars is going to be different than the paradigm for approving new biological entities. And so this paradigm really focuses on that analytical similarity versus the exercise of clinical safety and efficacy. So I think it's incumbent upon ourselves to be educated about the data regarding biosimilars and thus transfer that over to our patients so that they'll feel comfortable about these products as well. Dr. Brufsky, do you have anything to add to that?
No, not at all. I mean, I think that the bottom line here is that communication is key, and I think that, just incumbent of all of us as healthcare providers and people that, are involved in kind of managed care to provide that information to people so they can understand what biosimilarity really is, and these drugs are actually have to be similar in very specific ways. But I think the key is that communication is probably the biggest thing we have to worry about.
Right, absolutely. Thank you for those thoughts. Being that we're at the top of the hour and there aren't any other questions that I see, I'd like to go ahead and conclude the webinar. But before I do that, I'd like to ask Dr. Brufsky if you have any final closing remarks.
Just that, I just think that, it's a great time to be involved in the treatment of metastatic HER2-positive breast cancer because we have a whole variety of new agents and the opportunity to really change the natural history of this disease.
Great, and I'd just like to add that these advances, while they're great, do add a bit of cost to our overall treatment of this disease. And in today's cost-conscious climate, we really need to think about how we can reduce these costs and provide the most cost-effective care. Certainly, following pathways and guidelines will help to reduce variability, reduce inefficiencies, and provide the most effective care, but I think having biosimilars to help us compete in the marketplace on price will certainly help to moderate the growth of the expenditures in this area. So with that, I'd like to thank all of our listeners for attending today's webinar. To be eligible for continuing education credit for today's activity, please log on to www.naccme.com. That's www.naccme.com. Successfully complete the 10-question post-test and evaluation form, and immediately print your documentation of credit. This concludes today's session. Thank you again for joining us, and have a great afternoon.